Good evening, everyone. Welcome to Master Classes in Critical Care Medicine from Yashoda Hospitals in association with ISCCM Hyderabad chapter. So, we have a case discussion today by our DrNB students, Dr. Sindhuja and Dr. Vignesh. Both are final year DrNB students. And to take through the case, we have senior teachers, Dr. Rajesh Pande sir. He is director and head of the Department of Critical Care Medicine from BLK-Max Super Speciality Hospital, New Delhi. And another examiner we have is Dr. Ravindra Ghawat. He is Director, Department of Critical Care Medicine, Jupiter Hospital, Thane, and he is a West Zone member of from the to the ISCCM. So over to you, Rajesh sir.
I welcome viewers on behalf of Yashoda Hospitals and the ISCCM Hyderabad chapter. And we have two DrNB students, Dr. Sindhuja and Dr. Vignesh. And what we are going to discuss today is a case which is still admitted, and it's a case of polytrauma. So this will help the students in understanding how to present the case, how to be systematic about the case, and what interventions would be made by the examiners if they need a specific directions you to take, be more precise and focused. So I think who is going to present first? Dr. Sindhuja, you or Vignesh?
Myself.
Okay, so we have Dr. Sindhuja who will be presenting the case. Dr. Sindhuja, welcome and thank you for participating. So you can begin with your case.
Thank you. A 23-year-old male brought to the ER with history of skid and fall from the bike 1 hour back, who has sustained injury to the abdomen, right hand and leg, with no history of loss of consciousness, vomiting, seizures, head injury, ear or nose bleed. History was given by the patient.
Dr. Sindhuja, can I interrupt you here? When you are presenting, it's like you're presenting to the examiner. So you should be starting with, I am presenting a case of 23-year-old male. So that's the correction that we need to make. You can move ahead, okay? Don't go back, just move ahead.
On primary survey, airway is patent. Breathing decreased right basal breath sounds. Tachypnea with respiratory rate of 32 per minute. Saturation 89% on room air and 95% on 2 liters nasal bronch oxygen support. Chest compression test is positive. No tracheal deviation is. Circulation BP is 70 by 50 with pulse rate of 130 per minute. All peripheral pulses felt equally. On E-fast, free fluid is found in the right hepatorenal pouch and minimal collection in the right pleural cavity. Pelvic compression test is found to be positive. And GCS E3 V5 M6, drowsy, pupils bilateral, equal size reacting to the light, no focal deficits, aberration and right bony crepitus is found on the right side. Temperature is 98 degrees Fahrenheit and patient is exposed to look for the external injuries and examination and covered by.
So one question to you, do we include E-fast in a primary survey now, or this will come later when you are doing your investigation and other examinations?
The primary survey, any life, as the patient is in the hypotension, to
know the cause of hypotension, the patient has been evaluated with E-fast in this case.
No, generally, when you are saying you are presenting a patient who is hypotensive, tachycardic, after you have done your E, you will say we did, E-fast and these were the findings. These were the reason for his circulatory shock. Because let the ABCD flow like that and then comes the E-fast, the first thing that you do, because this is how you do it in your clinical practice, because you would be starting the monitors, putting on the lines before you jump on to E-fast, because that is, if at all you find something, you will need to pump in fluids or blood or something like that. So follow what you do clinically in your ER where the patient has come.
Yes.
So just to add, Dr. Vignesh and Dr. Sindhuja, Dr. Ravindra joined us. Dr. Ravindra, welcome you to the masterclass program. Can you just adjust your camera, sir?
Yeah, we can't see your face, so you have to.
I think maybe Yeah, sir, it is better.
It is better.
You can adjust the camera a little bit, sir, if possible.
Camera or the screen. You can lower your screen a little bit.
It's going back, sir.
No.
And now it is okay, but it's slowly going back. So just to re-emphasize, in this primary surveys, if you are in a peripheral center or you are in a place where you don't have all these equipments and you wanted to actually evaluate this patient in a quick time, in the easiest way possible, what will be the quickest way? In a 10-second, you will try to know that your ABC is patent or intact.
Patient is conscious and able to speak.
So something else, there is a specific way it has been mentioned in any of your formats.
The patient breathing is normal and the patient is able to speak. Generally, there is no injury and airway is patent. Breathing also looks okay. Then that should be out of the picture. And we look for circulation by capillary refilling test.
There is a specific question I am asking. What is the way you will know that this patient airway, breathing, circulation are intact? Generally, if you, the dictum is you ask your patient the name, details of it and the incidents. If somebody who can clearly tell his name and also he recollects and tells you about the incidents, that gives you in a quick time, within a less than 10 seconds, that he is conscious, his mental, cognitive function and cortex is intact. And he can actually, his airway is patent, otherwise he will not able to speak to you. And he can, if he's speaking to you in the lines, his breathing is not that badly affected. And if his circulation is intact, his brain circulation is gone. So this is not about what you, me, or any personal way of handling. This is what is a standardized way of assessing the patient. If you wanted to assess a patient, you ask his name, details, and the incidents. If he's able to give you, that's the quickest way to know in 10 seconds about the patient's stability at that point of time. Other than, as Dr. Pande sir was rightly pointing out, you say he fast first. Because you do practice sometimes he fast, because it became a fancy word that you have a focus, you have a e fast in A. But in an exam point of view, they may say you are in a site of trauma, you are in a center where you don't have every facility available. So in a flow also, these are the particulars which you need to know. And this is a part of ATLS now. Sir, over to you. Sir.
Yeah. Usually, if a patient can complete one complete sentence, when you speak to the patient, if the patient can complete one sentence without breaks, then it usually, makes you sure that his mental status is reasonably good and the breathing problem is not very serious.
Dr. Sindhuja, you had mentioned that you had taken, the history was given by the patient himself, correct? So that means patient was speaking. So that highlights, the points that Dr. Venkat Kola made. So I think the flow should be as is taught to us in medicine when we are presenting a case. Okay. Yeah, I think you made your point. So what are the key issues here in the primary survey? What are the problems here that you can identify?
Patient is in hypotension and tachycardia and mild tachypnea is there, requiring minimal amount of oxygen.
Yeah, you said he was desaturating on room air, correct?
On room air is 89 to 90% saturation.
Okay, so when you have this kind of a patient, when you have done your primary survey, what do you do besides this? What goes hand in hand?
Adjunct to the primary survey and resuscitation.
Resuscitation. So what do you need for resuscitation?
Securing the IV cannulas and giving fluids.
Okay.
And giving oxygen support.
Okay. So I would appreciate if you say that the patient was connected to a monitor with, say, heart rate, NIBP, oxygen saturation you already mentioned, and two large bore IV cannulas were inserted, and crystalloid solutions were started. And then you can say immediately we did an E-fast evaluation, and because you are supposed to go in that order, and E-fast revealed whatever findings you have, showed. Those findings can be mentioned there, because then you are done. Okay. Because when you are putting the cannula, somebody will be collecting the samples also, correct? So what are the samples that people will collect when they are putting the cannula in a trauma patient?
CBC, blood grouping and cross-matching, electrolytes, and for coagulation profile.
What for coagulation profile? Mention the test, name the test.
PTA, PTT, and INR.
PTA, PTT, and INR. These are the tests that you generally send for, okay? And so, okay, you can move ahead now.
Only 2 18-gauge IV cannulas were secured and 1 liter of crystalloids bolus was given. There was improvement in baby with the fluid bolus to 90-60 millimeters of mercury on NORAD of 0.1 mics per kg per hour. Injection tranexamic acid of 1 gram IV bolus was given, followed by infusion.
Okay, if we stop here for a moment, you mentioned about EFAST. Many of the students may not be practicing trauma. They may not be familiar with EFAST. If you can elaborate something on EFAST, how do you do it and what are the things that you can pick up immediately?
So we take up a curvilinear flow and basically look at the four quadrants basically. One is a hepatorenal pulse, splenorenal pulse, pelvic, and we look at the heart to look for a cardiac tamponade.
Dr. Vignesh, Sindhuja's sound is much better. So if you can come closer to the mic. Yeah.
Okay. So we look at the 4 quadrants, right hepatorenal, splenorenal, and we look at the pelvic and also look at the heart to look for any tamponade effect is there. And so that is fast. And adding EFAST is nothing but look at the lungs also to rule out any life-threatening illness like hemothorax or tension hemothorax system.
Excellent. Yeah. Dr. Sindhuja, please continue.
ABG showed metabolic acidosis with pH of 7.23, PCO2 of 28, PO2 of 88, and bicarb of 13.6 with lactates of 13.5 and base excess -10.
So my question is, why ABG is important in trauma?
So currently the ATLS guidelines actually tells to concentrate on base deficit actually. So target our resuscitation based on base deficit. So that's why ABG will play a key role in this case.
If you look at it historically, lactate has been found to be a very good marker for hypotension and tissue hypoperfusion in trauma. So that story continues from the 60s. If you look at the current, the guideline, European guidelines published this year, they still consider lactate as the best marker and they say base excess to be done if lactate is not available. But I agree with you. If you're following ATLS, that base excess, because it gives you the quantum of the problem that you have. So indirect marker of hypoperfusion. So one question, when we talk of say any shock, say for example, septic shock, what are the downstream markers that we talk about? Where does lactate and base excess figure there? It's not related to trauma, but these are the downstream markers.
We take lactates as actually a downstream marker in even in septic shock. So we look more of a clearance of lactates in septic shock basically to look for fluid responsiveness.
Anything else which is recommended now there? Capillary
refilling time will tell us. Go hand in hand as per antivenom shock trial.
There are other things also, but we'll not go into those details. You can continue with your case presentation, Dr. Sindhuja.
Ordered for 2 units of type-specific PRBC for transfusion stat and for reserve of 2 units PRBC and 4 FFPs and RTPs. Secured Foley's catheter and labs were sent. Bedside chest X-ray showed right CP angle blunting with 10th and 11th grip fractures. And right leg X-ray showed right displaced femur fracture and right hand showed undisplaced both bone fractures. The right lower limb was splinted and the right upper limb sling was applied.
Okay.
Coming to the secondary survey, no history of allergies or past medication or medical history. Last meal was taken 2 hours back. Mechanism of injury, skid and fall from the bike under alcohol influence. Head to toe examination, head and neck, no external injuries, no spine tenderness. Chest compression test was positive, decreased right basal breath sounds. Abdomen and pelvis, tenderness all over the abdomen, more on the right upper quadrant, and the pelvic compression test was positive. Abrasions were found on the right lower abdomen. Bowel sounds were present. Foley is secure. A musculoskeletal examination, right arm tenderness was there. Right thigh laceration and multiple aberrations, and abrasion over the right lateral foot. So he was shifted to CT polytrauma and then shifted to the ICU.
So what is CT polytrauma? Do you mean whole body CT scan in trauma?
Yes.
Yes.
Okay. So what are the situations in trauma where we have to go for whole body CT scan?
So when the patient, someone is under the influence of alcohol, unoriented patient who's not able to give a proper history and the mechanism of injury, and person having persistent hypotension, as in this case, even after fluid resuscitation, those patients warrant actually a CT polytrauma to look for any evidence of bleed or any missed injuries.
Absolutely. So if we, have to summarize, then a patient who is in hypotension, systolic BP less than 100, patient who has lost more than 500 ml of blood, and patient who is whose GCS is say less than 12 or 13, and there is a abnormal pupillary reaction. In addition, we can have, fracture of two long bones, severe abdominal injury, pelvic fracture, unstable vertebra, spinal cord compression, and patient who has fallen from a height, because you need to look at the fractures in the spine and elsewhere, and also when there is a wedged or trapped chest and abdomen. So these are specific situations where you have to go for a whole body CT scan. So what do you do in a whole body CT scan, if you can elaborate on that?
So we generally look at the CT brain, chest, with CT brain with the cervical spine, CT chest, abdomen and pelvis, and all the arms, lower limbs and upper limbs as well.
So if I can ask you to just tell us again the EFAST findings that you had.
Minimal collection in the right pleural cavity and free fluid in the right hepatorenal.
Okay, and pelvic compression was positive. Okay. Okay, let's see what we found in CT.
CT brain, no abnormality found. CT chest, right 10th, 11th rib fractures were found with mild hemopneumothorax with underlying lung collapse. And CT abdomen, grade 3 liver laceration with mild hemoperitoneum. CT pelvis showed right the superior and inferior pubic ramus fracture and acetabular fracture. CT spine, T12 and L1 spinous process fracture, and right arm both bone fracture, and right femur displaced shaft fracture is.
Now I have a question. Your patient was hypotensive. You did an EFAST, which showed you some findings. So do you think we needed some intervention before shifting him for a whole body CT scan?
So there was only a minimal fluid collection just seen in the lungs there actually. So that's why the patient was not intervened at that point.
Okay.
And we have placed a pelvic binder for the patient who's having a compression test positive, pelvic compression test positive.
So approximately how much is the blood loss for a long bone injury or for, say, this pelvic fracture?
Femur fracture around 1.5 liters and humerus fractures around 600 to 800 ml. Pelvic fracture around 2 liters.
2 liters.
So that means there was a substantial blood loss that you were expecting, correct? Okay, yes. Which is not explained by the hemothorax that he had, mild, minimal, correct?
Yes,
okay.
Sir.
Okay, please proceed.
After shifting the patient to the ICU, they had increase in the tachypnea and desaturated to 85% on 10 liters oxygen, with increasing the NORAD support. Repeat EFAST done showed no increase in the collection. Pelvic binder and right upper limb splint were in place, and right upper limb sling was also applied. There were decreased right breath sounds, so suspected of pneumothorax, tension pneumothorax. Right ICD placed immediately, and 200 ml of blood along with the air bubbles were drained. The labs were collected by that time. HB showed 8 grams, total counts of 90,000, platelets 1.5 lakh, creatinine is 1, INR 1.5, LFT showed bilirubin of 1.4, SGOT 45 and SGPT 42.
What is your interpretation here of these findings?
The patient had a worsening desaturation, maybe because of the worsening pneumothorax which was found on the CT scan. So that could have worsened and the patient had an immediate insult. So ICD was placed and the pulse certain patient was immediately stable.
So oftentimes, Dr. Vignesh and Dr. Sindhuja, when you have these findings and you are shifting the patient from gurney to the trolley and then to the bed, so, you know, because of the rib fracture, these lung injuries may aggravate. So possibly a word of caution here for all of us who are managing these patients with a small pneumothorax, which turned out to be, increased significantly in the ICU. Yeah, please.
After transient improvement in the blood pressure, patient continued to have the hypotension despite ICD placement. He was drowsy, obeying commands. Temperature was 97 degrees Fahrenheit and BP continued to be 80/50 on NORAD support. Heart rate is 135, rapid 30 pulse and cool extremities were found. Mild tachypnea requiring 5 liters of oxygen support with saturations of 92%. Urine output was around 30 to 40 ml per hour. And to rule out, evaluate for the reason of the hypotension, repeat EFAST was done, which showed mild increase in the collection. And ABG found to have metabolic acidosis with the pH of 7.22, PCO2 39, a PO2 of 78, and bicarb of 16. Lactates were 5.4 with base excess of -11. And HB in the ABG was 6.5. So repeat CBP, INR and fibrinogen levels were sent. And as there was a mild increase in the collection in the EFAST, we wanted to rule out further active bleed in the abdomen or right lower limb. And so CECT and right peripheral angio was done, which showed no active contrast leak in the abdomen and no major artery bleed or injury in the peripheral lower limb.
You had arranged for blood and transfused some blood before that you presented in the earlier slides. How much blood have we given him so far?
2 units PRBC were given. So since
and how many more were arranged to be given later?
4 units PRBC, 4 MCs were results.
Okay. So what would you be targeting when you are transfusing blood or doing volume resuscitation? What blood pressure are you targeting here?
Mean arterial pressure of more than 65.
Why are you targeting mean arterial pressure more than 65? Dr. Vignesh, do you agree with her?
So in a patient who is having ongoing bleed, even we can consider to target a lower mean arterial pressure. Of 50-55 can be targeted.
Dr. Sindhuja, we generally target lower values unless there is trauma to the brain or spinal cord in a major way, because if we are targeting normal values, then the bleeding obviously will increase and the spurters will open up. So a map of 50 to 60 in those situations is said to be good enough. Okay. So you can label it as hypotensive resuscitation of the targets are lower. They are not above 65. But the target would be normal restoration, systolic BP 65 or more. If your mean arterial pressure more than 65 millimeter mercury, if your patient has intracranial bleed or traumatic brain injury or major spinal injury. Okay. Yeah, please continue.
Labs showed hemoglobin of 6.8, platelets of 1.2 lakhs and INR of 2, fibrinogen 180. And 2 PRBC and 4 FFPs were transfused in view of low HB and INR of 2. BP was improved to
what hemoglobin are you targeting here? We talked about the blood pressure.
We are targeting a hemoglobin of between 7 to 9, sir.
So 7 to 9 would be good enough. Correct. Okay, please. Dr. Ravindra, you wanted to say something.
Yeah. Do you have targets for platelets, INR and fibrinogen also?
more than 50,000 of platelets.
Sorry?
INR of less than 1.5, platelets of more than 50,000. If traumatic brain injury is also there, then more than 75,000 is targeted. Fibrinogen of more than 110 is given in some places and 150 in some places has been mentioned.
Around 100, yeah. More than 100, 150, okay. And INR?
0.5, less than 1.
So you said that you would have one blood, one PRBC to one FFP to one platelet ratio, right? Do you have any evidence for this? Why 1:1:1?
So by giving 1:1:1, the dilutional coagulopathy is actually been prevented. That is why we go for 1:1:1. There is also studies to support 1:1:2, but both the proper and prompt trial doesn't support giving 1:1:2, and maybe a prompt trial showed some early benefit giving 1:1:2.
Actually, if you see the European guidelines, they recommend 1:2 now, the 2030, 23 guidelines. Yeah. So anyway, since you have quoted that you are, talking about ATLS, we'll accept that. It's a surgeon's thing, so absolutely fine.
So apart from dilution, what are the other reasons why they can be coagulopathic?
Consumption coagulopathy.
Consumption coagulopathy and?
Hypothermia.
Hypothermia, yes, very good. And?
Acidosis.
So what is this called? It's called
the
triangle of death.
Why there is a role for antifibrinolytics? Why there is a role for antifibrinolytics? No? Tranexamic acid.
You gave in the beginning.
Yeah.
In the CRASH-2 trial, there was a reduction in the mortality at 28 days when the tranexamic acid of 1 gram start followed by infusion for 8 hours when given within 8 hours of incident of trauma.
Both all-cause mortality and bleeding unit mortality is decreased.
Okay, suppose hypothetical question, your pharmacy doesn't have tranexamic acid, but the pharmacist tells you that, sir, madam, I have recombinant 7A. So can you use that?
No role as such in trauma as of now. Maybe in liver lacerations, after replacing all the products, still the patient is bleeding, they have tried, but currently there is no role of factors.
Absolutely. So the viewers must remember that there is off-label use of recombinant 7A, which is only suggested when all other therapies have failed. It's a last resort, not the first resort. Whereas tranexamic acid after this CRASH-2 trial is one of the things that you give early on. Okay?
And there is a massive release of tissue plasminogen activator during the trauma from the damaged endothelium. And that's why you have an activated fibrinolysis, and that's how antifibrinolytics work in the initial phase of trauma.
So now what is your hunch here? Because you found that the bleeding was, hypertension was more, but and there was an increase in the collection. When you did your angio, you didn't find any contrast leak in abdomen, no major artery bleed in the leg. So what is happening to the patient?
We diffuse the bleed from the multiple fracture sites. From pelvic fracture and femur fracture, soft tissue injury was there. And mild hemothorax was also there.
Okay, so what you are suggesting is there was no need for any intervention except, looking after the volume and the blood loss, correct?
Yes.
No radiological intervention was required.
Yes, sir.
Okay. Yeah, you can move on. Yeah.
On day 2, patient was conscious, obeying commands, and the pupils are equal size reacting to light. Temperature is 98.4 degree Fahrenheit. He was requiring 4 liters of oxygen support with respiratory rate of 28 per minute. He was off vasopressors, maintaining BP of 100/60 with heart rate of 100 per minute. And urine output is around 50 ml per hour. Abdomen showed no increase in distension. Mild right upper quadrant tenderness was seen. ABG, pH is 7.33. PCO2 of 41, PO2 of 92, and bicarb of 21 with lactates 3.1 and base excess -4. Labs showed hemoglobin of 8.2, total counts of 14,000, platelets 1.2 lakhs, creatinine 1.1, electrolytes sodium 137, potassium 4, and chlorides 100. LFT showed bilirubin of 2 and SGPT slightly raised. INR is 1.6. He is on IV fluids 80 ml per hour on NBM planned for femur fixations.
Okay. So do we have another case or this is the only one?
This is the only
one.
Okay. Now, suppose this guy was lucky that he didn't get a head injury. Suppose the same patient, after alcohol intoxication and with falling from a bike, he was brought in an unconscious condition, unresponsive condition by the police with little or sketchy history available from bystanders, only about the fall, not about his other things. So how will your priorities change in that situation?
The primary survey still remains the same, sir. Airway, breathing, and circulation, all will remain the same. We would look for an early CT brain will be done to look for any brain injuries. Actually, should take priority in this case, and to rule out any other TBI and polytrauma will be.
So before that, airway and breathing would be significant issues. Okay. If this patient is also having, C, that is hypotension or shock, then it makes it very difficult. That means airway interventions would be required. You need to evaluate from that point of view also. So my question to both of you is, when would you think of intubation? What would prompt you to take that call immediately?
Attend airway and risk of aspiration.
So generally what we say is Glasgow Coma score of 8 or less.
Less than 8.
Yeah. And patient is unconscious, or there is airway obstruction that you can see. What else?
Patient is not breathing normally.
Patient is not breathing. There is significant degree of hypoxemia, very, very high degree of hypoxemia. So that is the situation where you will also think about it. And when you talk about B, how do you ventilate these patients?
Brain injury, sir.
No, yeah, brain injury or non-brain injury. Suppose your patient had no brain injury, but he was unconscious because of shock, significant blood loss, and airway was compromised. So you tubed him. Now, what kind of support would you like to give him on ventilator?
Lung protective ventilation, routine lung protective ventilation.
Excellent answer. Excellent answer. And targeting?
Targeting saturation of 90 plus and carbon dioxide of 35 to 40.
You would be targeting normocapnia, correct?
Yeah.
And what are the situations where you would go for hyperventilation?
If the patient warrants an emergency decompressive craniotomy in view of increased ICP, momentarily we can do hyperventilation. Just because
only if you are thinking of brainstem herniation, correct?
Yes.
Otherwise, there is no clinical indication, no role of this hyperventilation on a ventilator. So we target normocapnia here. Okay.
So will you give sedation to this patient if you are intubating? What are your concerns while intubating this patient?
How will you intubate? Yeah, that's an important question.
Rapid sequence intubations.
What is that?
We'll do with C-stain stabilization, sir. So manual stabilization, and we'll give a use etomidate 0.3 milligram per kg of body weight. And
so Sindhuja, this is very, very important. Manual inline stabilization of the C spine. Okay. So, and then you come to the drugs and other things. Okay. How will you choose the agents and in what doses would you give? Suppose he's a 60 kg adult.
Rocuronium 1.9 to 1.2 milligram per kg IV.
Sorry, what?
Rocuronium.
Would you know any induction agent, any sedative, anything else before that?
Yes.
Yeah, etomidate of 0.3 milligram per kg can be used.
Can be used in exam. We want to know what do you do in your hospital? What is done in Yashoda Hospital? Tell me that.
Etomidate 0.3 milligram per kg.
Okay, so for this patient, how much would that come to? 60 kg. 18 of what?
18 milligram.
18 milligram. Okay, yes. So that is your rough dose. What else after you have given etomidate?
Rocuronium.
Do you give vecuronium?
Rocuronium.
Rocuronium. Okay, rocuronium. What dose?
1.2 mg per kg.
So that would be how much?
60.
70.
Around 80 to 90 milligram.
Okay, so you have paralyzed the patient. Would you be doing any pre-oxygenation before that?
Yes, sir.
Pre-oxygenation with 100.
How will you do?
How will you do? Yeah.
Will you ambu ventilate or will you
Sir?
ambu ventilate or you?
For pre-oxygenation, we give 100% oxygen and wait for 3 minutes.
So if there is airway compromise, how would you maintain the patent airway until you have put a tube?
So we can do chin lift and jaw thrust maneuver to maintain the airway.
So what should not be done until and unless intact C-spine has been proven?
Head tilt should not be done.
Head tilt should not be done. Okay.
The patient is already having a malalignment stabilization, so I don't think that will be even possible to do.
Okay. So
anything else you do in an RSI? A very important thing.
Cricoid pressure.
Sorry. Any important thing that you do in an RSI?
Cricoid pressure.
Trauma.
Patient
who is full stomach.
Cricoid pressure. Evidence on cricoid pressure is still dicey, sir. So we don't routinely follow that.
Okay, one basic question. You showed the primary survey. So is there any change in thought process regarding primary survey in ATLS? They are now trying to call it CABCDE, where C stands for critical bleed. That has been given the top priority. That if there is critical bleed, then you have to focus on that. And it may require rapid bleeding control along with resuscitation. So CABCD is the emphasis that ATLS is giving now. C stands for critical bleed. Yeah, please. Dr. Ghawat, you were asking something. Dr. Ravindra, you were asking something.
No, I was asking about whether you will apply cricoid pressure or not, or if you have to apply, when will you release?
If at all we are applying cricoid pressure, we'll release after the tube is in place and cuff is inflated.
Cuff is inflated. Okay. So what is the current status? What does ATLS say about it?
No evidence to support.
It's become controversial. Yeah, it's become controversial, but we are old timers. We still use it. Okay. Dr. Sindhuja, you can move on with your case.
GCS was E4P5 with a mean arterial pressure of 75 and heart rate of 100, urine of 60 ml per hour. Is requiring 2 liters of pumps. Lab showed hemoglobin of 8.5 and platelets of 1 lakhs, 14,000. Readmission of 2.8. SGOT and SGPT were raised compared to previous day. INR was 1.3. ABG showed of 7.34 and the PCO of 37 and the PO of 75. Bicarb 20 with lactates 2.6. The patient was taken up for right femur and right upper limb both bone fixation. 800 ml approximate blood loss was noted and 2 units intra.
Dr. Sindhuja and Dr. Vignesh, since hemorrhage and blood loss and hypertension are the major concerns here, and we have been pumping in blood units, how do we classify this hemorrhagic shock in terms of blood loss? Is there a way to classify it?
We classify stage 1, 2, 3, and 4 based on the amount of blood loss in comparison to the blood volume. So less than 15%, 15T, 30 to 40, and more than 40. That's how we classify the blood losses. Clinical markers will be in stage 1, there will be just increase in heart rate with all the other perfusion markers, including BP, will be maintained. And in grade 2, there will be slight bit of hypotension will be there in grade 2. In grade 3, there will be tachycardia will further worsen and the heart rate will be more than 120. And in grade 4, will be more than 140. And as I'm base is also.
How does this classification affect your resuscitation goals or resuscitation? How does this classification of shock affect your resuscitation?
Falls into grade 3. The patient falls into grade 3 or 4 of the category, then the flex need to be there. And
so usually up
grade
to
4,
grade 1
you
don't have many signs. So at grade 3, you start getting many signs, and even the base deficit starts increasing, right? And you might need blood because at grade 3, you would have lost around 30% of your blood. The patient would have lost around 30% of his blood.
And maybe decrease in urine output becomes a significant feature here in grade 3 and grade 4.
Grade 3.
So this is called American College of Surgeons classification of shock, which is still being followed because it's by surgeons, and the ATLS is a byproduct of the surgical societies. Okay, so what was done here? You said right femur and right upper limb, both bones were fixed. Okay. So if you have to evaluate this patient for risk of surgery from an aesthetic point of view, what are the factors that you see here? Where does it fit in ASA?
ASA 1 only.
Dr. Sindhuja, you agree with him?
It's not a running. So
ASA, you also have to mention emergency surgery besides ASA, isn't it?
Yes, sir.
So it would be.
The surgery was taken on day 3. So
okay, surgery was taken on day 3. Okay. So ASA grade 1, who is undergoing surgery for the long bone fixation of arms and legs. Okay. What happens now? Can we move on with the case?
So in a patient who has bleeding from the femur fracture or a long bone fracture as a cause of your hemorrhagic shock or hypotension, what are your other concerns if the patient has long bone fractures and is in hemorrhagic shock?
Concerns can be one, an ongoing bleed. Other thing can be the patient can land up in fat embolism.
Obviously, the next question would be, how do you identify fat embolism?
So it consists of a constitutional symptoms of desaturation or desaturation with neurological problem as well, and subcutaneous manifestations. So these 3 will form the triad of fat embolism. Identification, if you want to do, we can do a BAL, and we can see for some lipid and macrophages can be seen sometimes. We don't do routinely.
Are you also worried about some compartment here?
Yes, sir. Compartment syndrome.
So how do you look for it?
It's a skeletal trauma. So what else could be problems here? And if you can elaborate about compartment syndrome also.
With the wounds from the injury and the soft tissues and pressure from the fracture, the musculofacial compartment will be, the pressure in the musculoskeletal compartment will be increased, causing the pressure on the muscles. That will cause the compression of the artery and the nerves there.
The patient will have out of proportion pain, paresthesia, and pulselessness will be present in the last stage.
Anything else could be there because of crushed muscles, which requires
rhabdomyolysis could be.
Rhabdomyolysis, the patient will be.
What is the problem with rhabdomyolysis?
Okay.
The patient will land up in AKI because of the rhabdomyolysis, because of ongoing muscle destruction.
How will you identify?
Globulins will go and
How will you identify rhabdomyolysis?
For myoglobin or cola colored urine with creatine kinase of more than 10,000. So
And suppose you find that kind of a picture, what will you do?
adequate hydration with alkalinization of urine. Diuresis.
What electrolyte abnormality you get in the rhabdomyolysis, which can be very dangerous.
Hyperkalemia.
What do you do if there is severe hypokalemia?
Hypokalemia, sir.
Hyperkalemia. If there is severe hyperkalemia due to rhabdomyolysis and.
So we'll initially start with calcium gluconate, giving a dextrosyncillin solution, salbutamol nebulization. If nothing works out, then refractory, then we even do dialysis.
My suggestion to both of you is in the exam, mention specifically how much glucose, how much insulin, how much calcium would you be giving to the patient. Okay. Your answer should be as if you are giving the drug prescription orders to your nurse. Orders to be carried out. Generalizations are for the consultants because we can't remember things, but from students, we expect that they remember each and everything.
We give
So
10
doses.
ml of 10% calcium gluconate over 10 minutes and 100 ml of 25% dextrose with 8 to 10 units of human actrapid.
Okay, and how much calcium would you give?
10 ml of 10% calcium gluconate.
What is recommended now? Is it chloride or gluconate?
Whichever is available, sir. So in India,
Whichever. But now calcium chloride is also available. Anyway, I'll accept your answer, but the recommended one now, especially in the new guidelines, is calcium chloride. They only talk about calcium chloride. Okay. And since you have been pumping in some fluids also, tell us something about the intravenous fluid resuscitation in trauma patients. What fluid to choose and what fluids to avoid and why?
We choose crystalloids. There is currently, because colloids have no role, because HES has been shown to have AKI and related complications. And
No. The reason in trauma patients is a little more. It's a little different. Large volume colloid will interfere with coagulation.
Coagulopathy.
They can precipitate coagulopathy. So that's the main reason, because in septic situation, we don't use them. They're contraindicated in sepsis. Level 1 indication, because there is a capillary leak there. So they may leak out, they cause AKI, more incidence, and more need for RRT. Okay. So we don't do them, maybe higher mortality. Anyway, what else? So in crystalloids, what will you choose? Choice of fluid.
Both can be used, sir. Sodium chloride as well as finger lactates, both can be used. There is no specific thing, but there is a risk of hypochloremic acidosis if you are going more than 2 to 3 liters of sodium chloride, sir. But as I said, we generally switch over to blood and blood products at the early stage trauma. I think both the crystalloids should play.
Okay.
There is no.
So if the patient has head injury, will your choice of fluid differ there?
We'll give only NS, sir, actually. Normal cylinder fluid, and we'll avoid albumin. Again, colloids
what about albumin?
Not
using albumin as a colloid for resuscitation in trauma?
No, sir, we don't use.
No, but why? His question is why.
One, before, as you said, it can cause dangerous coagulation. Secondly, in TBI, as per SAFE2 trial, it has caused worsening of neurological outcomes.
Yeah, the post-hoc analysis of the SAFE study showed that the mortality was higher with albumin use in the traumatic brain injury group. It was lower in the septic group. But the study was not powered enough to comment on these mortality. That was not the primary question. Okay, what about, are these generalization we can use for any trauma, or there you would like to differ some, do things differently in traumatic brain injury? in terms of fluid resuscitation? Well, we do not use large volume of ringer lactate there because it's a hypooncotic, fluid, and this may increase the cerebral edema. So large volume ringer lactate is avoided in patients with traumatic brain injury and cerebral edema. Okay. So, is there more to your story? Something more happened in the HDU, or the patient improved and was discharged and went home?
Discharged and went home.
Okay, so we will have to do something. What are the suggestions that you will give to your anesthesia colleague when he's taking up this patient? Suppose it's a prolonged surgery. Suppose they want to fix up the liver also. Okay, along with the two bones. So what advice would you offer to him?
Lead and lead products, maintenance of optimal temperature.
Maintenance of optimal temperature, reduce any heat loss, correct? What else? You can advise them to use a salvage if it is available there, so they can use that. Okay. And what advice would you give? Suppose there is no long bone injury, or in addition to long bone injury, there is a major abdominal injury. There is hemoperitoneum. Then what advice would you offer to your surgical colleague, DrNB surgery, or maybe gastrosurgery? What advice would you offer him? Let me rephrase. Do you know about damage control surgery?
Yes, sir.
So what is damage control surgery?
Damage control surgery, they just go inside. The idea of damage control surgery is just to stop the bleeding and decontamination. And the surgery should not take more than 90 minutes. And they just do the packing, and they can do by the skin closure or with a Bogota bag or with a wax section, they have to come out. That is what has been.
So basically, whenever you have significant hypothermia, significant acidosis, or generalized bleeding, and the definitive repair needs more time, you would go for damage control surgery. At the minimum, this would be limited to just putting drains in the abdomen and peeping in and coming out. And once the patient stabilizes, then you go for definitive surgery. So that's the norm. So two things: the resuscitation, where you are targeting lower values, lower MAP, and then damage control surgery, so that the exposure to the OR environment is reduced and patient does not become hypothermic, and there is no increase in coagulation problems. So these are, and acidosis, these are some of the things.
So
okay,
that is a lethal triad of trauma. What is a lethal triad of trauma?
Hypothermia, coagulopathy, and acidosis.
Coagulopathy, hypothermia, and
Acidosis.
acidosis.
How much dose of tranexamic acid is recommended in these patients? And should we repeat it?
They have given 1 gram for 10 minutes and 1 gram for the next following 8 hours.
So generally they recommend that if the patient comes early within 3 hours of injury, then it is advisable. Correct?
Yes, sir. Yes, sir.
3 hours of injury when they are coming to the ER, because you gave the tranexamic acid in the ER.
Yes, sir.
And how will you use plasma or fibrinogen or cryoprecipitate or PCC, if you can talk about that?
Those things.
The blood products are not immediately available. PCC is.
Which hospital will have blood products not available unless it is rarest of rare groups? You are in my hospital, they have, and Dr. Shashidhar and
Patient is already on vitamin K, so then for rapid reversal of coagulation, PCCs can be used. And other factors like FFPs and cryo, if at all we did tech or ROTAM and based analysis, we did for an ongoing deep patient in trauma. Again, those things play a role after doing tech.
So that means if there is coagulopathy, or even if our PT-INR doesn't show any major abnormality, we still have to look at the platelet functions. That is where the role of this ROTEM and, other things come into picture. And generally, what is the amount of fibrinogen concentrate if it is available, or cryo that you have to use if you find that fibrinogen levels are too low?
15 to 20 ml per kg of 50 is.
Well, you have cryoprecipitate, so would you like to give that, or as a primary thing, you would like to give plasma?
Cryoprecipitate.
So how much cryoprecipitate would you be giving? Yes, please be loud. You're correct.
Same 15 units per kg.
Absolutely, because generally you need to give a high amount of this 3 to 4 gram of fibrinogen concentrate also. The equivalent would be 12 to 15 units of cryo. So that we need to remember. And if cryo is not available, these things are not available, then our choice is obviously plasma, but then volume is an issue there. Dr. Ghawat, you would like to add something here?
So in the pre-hospital survey, or when the patient reaches to your ICU or emergency room, now there is a new concept called as platinum 10 minutes. So initially it was 1 hour golden hour. Now the thing was that you had to resuscitate the patient at the field and then would ship the patient to a nearest trauma center. And the concept is changing to platinum 10 minutes, where with ongoing resuscitation you don't waste too much time in the pre-hospital setting and directly ship the patient to the nearest trauma center as early as possible. So now this is called as platinum 10 minutes. If you can reach the trauma center within 10 minutes, the outcomes are really become better.
These days, a lot of elderly may also get trauma. They may be on DOACs or other, agents. So what are the precautions that needs to be taken, or how will you handle those situations? I know those are difficult situations, but what are the suggestions?
The patient is already on DOACs, or so we have Idalizumab available. Suppose if the patient someone is taking oral anticoagulants of that, so if they got registered to the particular company, they used to provide Idalizumab actually to the hospital.
But that is only for dabigatran, isn't it?
Yeah, only for dabigatran.
Okay, so what is suggested that we can also think of tranexamic acid even here, and a reversal strategy. If the antidote is available, that is good. For other agents, for example, oral warfarin, you can use vitamin K. So those are some of the things, 50 vitamin K. So those are some of the things, but they would become customized. Possibly there you can also say that we will involve our hematologist as well as our cardiologist. So because trauma care is multidisciplinary, so always involve other specialties as well in your management. What about thromboprophylaxis? Because you are fixing up his femur and he cannot walk. One arm is also fixed. So what would you do? What would you recommend? The surgeon is afraid to give your LMWH or, the other, what do you call it? The sugar. What is the other thing that we use? The alternative?
Fondaparinux.
Or fondaparinux. So he is not keen to give any of these. So what will you use? How will you manage?
48 hours of surgery, generally either thermonuclear heparin or any thromboprophylaxis can be started. Even in the ATLS guidelines, from the onset of trauma, they tell after 72 hours, even after TPA, it is safe to start low molecular heparin as per the guidelines. If
but
we are afraid about both, then mechanical thromboprophylaxis only, then we can.
Absolutely. So the Europeans are more, clear on this. They say that mechanical thromboprophylaxis should be initiated So start it from the OR if it's a long surgery, continue until you can initiate the usual low molecular heparin or other therapies, pharmacological prophylaxis. So that is where, so let me ask you one question. What is the difference between pharmacological thromboprophylaxis, I'm not talking of trauma now, versus pharmacological plus mechanical combined, which is better? Dr. Sindhuja, any idea? Dr. Vignesh?
No role of combining both, sir. It's either mechanical or pharmacological. Pharmacological is deemed to be superior than mechanical.
A recent study has shown that when you are combining, that is no better than the pharmacological therapy alone. That is why these are not recommended by surviving sepsis guidelines.
Yes.
Based on a recent study where they could not show that this was superior. So basically, wherever you can use pharmacological thromboprophylaxis, use it. So reserve mechanical thromboprophylaxis only where either the surgeon is afraid or the protocol demands that we continue. There are situations where you can't use pharmacological prophylaxis. Dr. Ghawat, would you like to add something?
Yeah. So can you tell us what are the life-threatening injuries in a trauma patient? And how do you address them?
Tension pneumothorax, any cardiac tamponade, major vessel injury.
Okay. What else?
Or any multiple long bone fractures causing bleed. Yeah. Basically bleed.
Okay. Airway injuries, tracheobronchial injuries, right? They can also be life-threatening. Apart from this, any solid organ internal injury. Okay. Can you tell us which are the bleeding which may be missed by EFAST? Which are the structures which you may not identify or bleeding which you may not identify?
Retroperitoneal bleed and deep pelvic bleeds can be missed on EFAST.
Retroperitoneal, pelvic. Any other organ? Bowel injuries.
Okay, there are a couple of
pneumoperitoneum, then it becomes difficult to assess through a EFAST.
Sindhuja and Vignesh, there are a couple of questions which may have been answered, but because there is a demand from people who are participating from Indonesia, so I'll quickly ask you these questions. Which probe used for EFAST?
Curvilinear probe will be using for EFAST.
Curvilinear is the answer. Another question which you have answered, whether pelvic immobilization with binder should have been done before. That was done. That was done.
Yes.
Dr. Febrianto from Indonesia is asking, sorry, it's moving very fast. What is the first treatment priority for a patient with multiple trauma? If you can summarize. ABCDE, primary survey and resuscitation to go hand in hand. And like I said, now the emphasis is C, ABCDE. C stands for critical bleed. Yeah.
So if there is a circulatory shock or evidence of bleeding or suspected bleeding, then it becomes CABCD, which is being like a concept which is coming up.
Another question from Anisolo Nabila. How to intubate a patient with fracture, Lee-4-3 and mandibular fracture?
Lee-4-3 and mandibular.
Yeah.
We go for front of neck axis. Intubation can be tried, but preference will be to go for front of neck axis because Lee-4-3 fracture will have multiple fractures and bleeds will be also torrential actually because of Lee-4-3.
So that means we anticipate that this will be a difficult airway. So we need to have the strategies in place. An elective tracheostomy before any surgical procedure would be a good idea, correct?
Yes.
Okay. And you said, suppose we have the surgical access, the emergency access cricothyrotomy would come only when you are doing an intubation and you fail. If you're planning it, then that is not the plan. The plan would be surgical tracheostomy, or maybe percutaneous tracheostomy if you're confident. Another question is from Juan Sipta from Indonesia, Sibelas Merit University. He is asking whether there is any pitfall for using tranexamic acid to prevent trauma-induced coagulopathy or polytrauma.
Maybe if you're using in the late stage after 3 or 4 hours, there is some evidence of the thrombotic complications they have mentioned. Other than that, we don't know anything.
Okay, another question by Anisolo RB Rafal B from Sibilas Merit University, Indonesia. He says that sometimes procedural sedation is needed in trauma patients during preoperative examination. So according to your case, what is the best option of drugs to provide sedation in trauma patients? I think you explained your preferential choice for a hypnotic was etomidate, correct? Or would you like to think of why not propofol? Can you explain that?
It will cost more.
Can you use ketamine as well?
You can use ketamine as well, yeah. So that's another option.
Yeah. There is no TBI or anything. Yes, we can use ketamine.
Okay, one very interesting question by somebody who is MI. That's what I can see. Can we call multiple soft tissue injuries without bony injuries as polytrauma?
Should be two major organ, two system injuries with one long bone, or one system injury with the 2 long bone fractures. Actually, without long bone fractures, soft tissue injury cannot be called as a polytrauma.
Absolutely. Another question from Dr. Fernando Feliz Christian from Anesthesia Department, UNS Solo. He wants to know, how do you manage massive transfusion protocol in patients with chronic renal failure? You know, guys will ask only difficult questions, not the simple ones. So massive blood transfusion protocol in CRF patients, yeah, with trauma.
I don't think there should be any difference in the protocol as such, but care should be taken not to overload the patient in special.
And wherever required, I think you can combine the CRRT or dialysis modalities for fluid overload. So I think the priority would be to saving lives, and then CRF can be handled. Yeah, please.
Plus, you can probably warm them also. You can manage the temperature on the CRRT machine.
Yes.
So with massive transfusion, you can probably correct the temperature and prevent hypothermia. If you're putting the patient on CRRT, that will also accommodate your blood products as well.
Another question by Anisolo Maya Stuti Safira from Sukarta University in Indonesia. Where do patients go after they leave a polytrauma rehab center? So where did your patient go from the hospital? How is their healthcare program maintained?
Generally, a patient goes to a rehabilitation center. We don't have follow-up after the rehabilitation center. So
no, I'll answer that question. So generally, their physiotherapy starts within the hospital, and once they are ambulatory, then they can go and visit the physiotherapy clinic within the hospital, and subsequently that continues on an OPD basis. But in India, facilities are available where you can call for simple physiotherapy exercises, a physiotherapist at home also. But then it will be without any machine. So a follow-up with the physiotherapy department and supervised by the orthopedician is generally the rule. A different question. Somebody's concerned about the pain. So they want step ladder management of WHO, that pain management. This was a question asked to me in my MD in 1990, but I don't remember it now. So you guys are young, so you can answer this question. WHO step ladder therapy. But that's for cancer-related pain, not for trauma, if I remember correctly.
yes, sir. So it will combine, and for lower pain scores, we combine either a weak opioid with paracetamol or an NSAID. The next step will be to combine a strong opioid with an NSAID or paracetamol. The next step is will be going to invasive procedures like an epidural or any other modality of treatment of pain care will be taken. And it's always multimodal.
It's always multimodal, but generally we talk of this in context of cancer pain. There is a question by Aditya Kahya from Solo, Indonesia. So the question is, in patient of multiple trauma plus ongoing bleed, we should stabilize first, but on the other side, we should stop bleeding sources as soon as possible by surgery in OT. What is the perfect time for us to decide that patient can be taken up for surgery?
If there is an ongoing bleed, which cannot be compressible bleed by external sources, then the patient has to be taken to OT to control the bleed. Torrential pelvic injuries, which is having torrential bleed, Ribova can be used if it is available.
Or these kind of bleeds would go to the cath lab for any interventions.
Embolization procedures.
Embolization procedures.
So it depends on whether the bleeding is surgically manageable, where is the bleeding, and
Yes.
What intervention is going to help the patient in this particular type of bleeding. So depending on that, you will choose the intervention. So there are three types of patients that you can have. One are the responders, where you resuscitate, you give blood, and they respond and remain reasonably stable for some time, which means there may not be an ongoing bleeding, and then you can plan the surgery if required. The other one are non-responders who, in spite of resuscitation, they don't respond, the BP doesn't come up. These patients would require urgent intervention. And then there are transient responders, where after the resuscitation of giving fluids and blood, they would respond, go better on the blood pressure, and then again the blood pressure would drop. Now here probably you need to look for the source of bleeding, where you are missing something. And again, of course, these patients also need to go to the surgery after the resuscitation.
Another question by an anonymous attendee, Faras from Solo. Choice of analgesics in multi-trauma patients where patient is in shock or has severe brain injury.
Patient has severe brain injury. Already the patient will go on intubation and mechanical ventilation. I think fentanyl should cover the pain in those cases.
He's saying that patient is very sick. Maybe he's talking of hypotensive patient along with that.
Paracetamol can be used. Fentanyl again can be used with caution.
Propofol does not give any analgesia, so that is only for sedation, that the viewers should remember. So you have various choices, options available, so that can be used. And Rupak Banerjee is asking, what is the role of delayed sequence intubation in trauma?
I've never delayed sequence intubation. Sorry, sir.
Maybe he wanted to know about rapid sequence. Delayed sequence, I'm not aware. Dr. Venkat, Dr. Shashidhar, I've never heard about this term. So any idea?
No, sir.
So I think.
So the term is used where actually the rapid sequence intubation is not feasible in a situation where hypoxia is so bad. So they wanted to just oxygenate and then stabilize that. Because attempting oxygenation in a very severely hypoxic patient, somebody saturating at 20-30, you try to intubate them, they will into impending arrest. So pre-oxygenate them and delay the intubation in a sequential way and then intubate. That is the term they use for a delayed sequential intubation.
Okay, so same thing.
Hypoxemic patient, somebody who's in apnea for a few minutes and the patient saturations are bottom low. So oxygenate them, bring down the PaO2 in a dissolved form, at least to some extent, so that you will have some space to intubate them, because you need maybe a minute or two in an expert hands to intubate. So you don't lose that precious time to arrest the patient. And that is the word which they use, delayed sequence intubation.
I think this only is highlighting the importance of pre-oxygenation and maintaining oxygen reserves before you actually go for intubation. So I think they have given a name for this, delayed sequence intubation. This
is again important that you don't rush to intubate patients.
Absolutely.
Your idea is to keep them oxygenating. Your idea is to keep the cells alive. So like what we do in a CPR time or what we do in a trauma time, it is always to protect the airway, intubate them. But if somebody is in that state where you need some time and space to intubate. So you take that time in a controlled atmosphere. It's called delayed sequence intubation. That's what I understand. I think we can refer back.
Absolutely. But in situations where despite your attempts, you find that the hypoxia is persisting or it is worsening, then you will have to think of the, intubation or other modalities. So as long as you can maintain your patient nicely, you can delay until your team has gathered, your senior who has come from the floor, he's available. So I understand that would be a delayed. Ultimately, the process that you will follow will be the sequence of intubation, like you mentioned. But instead of rapid, now you are cautious and you are doing it in a sort of semi-emergency way. Anyway, that's what I understand. So I think we have answered most of the questions. Somebody's asking Dr. Ari August Saputra from Indonesia, Sukarta, epidural anesthesia for post-operative analgesia. So if you can elaborate on specific trauma where this is very useful and is practiced widely. Sorry?
I'm not sure about it, sir. It can be used, but I'm not sure pertaining to particular. Any abdominal trauma which is causing pain, maybe we can use it.
No, generally, if you have, say, thoracic trauma, then thoracic epidural gives you excellent analgesia, multiple rib fractures. Yes, because then the atelectasis and the pain are the significant issues. So after stabilization, you can, think of giving a thoracic epidural. So this is a good modality. But again, the coagulopathy should not be there. So maybe not immediately, but after the patient has stabilized and is now pain is a major concern. So more so with thoracic trauma.
The patient should be hemodynamically stable as well.
Hemodynamically stable as well. Yeah.
Cervical injury has been covered well, but there were now, at least these are the part of your at least case presentations, that when you actually evaluate a cervical spine, and you actually make sure that all these patients get some kind of hard collar or inline manual stabilization. But when these patients reach to the emergency room, what are the indications where you will actually go for a imaging in them? Will all patients with RT will go for imaging? All patients by default will go for a hard collar in the beginning before you evaluate. I understand that. Yes. Or those who are unconscious will go for a inline stabilization and then you take the airway in control. But what about the patients who are the RTA patient who will need an imaging?
We follow Canadian C-spine rule or nexus criteria to go for imaging. Canadian C-spine rule where there is any dangerous mechanism of injury, or if the patient is above 65-year-old, or peripheral paresthesias are there.
Neurological deficit is there, then we have to go for, or if some patient is on intoxication, not able to give any history.
Okay, agreed. So just to highlight these points that we use some scoring system. The other nexus scoring is?
Nexus is presence of intoxication, whether the patient is alert, obeying, oriented to time, place, person.
Nexus, you can actually use the nexus.
Neurological deficit. Ethanol ingestion, extreme distraction
injuries, neck mobility. If somebody having a posterior midline tenderness and neck mobility, tenderness during the neck mobility. These are all the mnemonics which have been used, whether we need a radiological imaging or some X-ray or a CT scan.
So one question that I want to ask you, we forgot when we were discussing about the circulation. What is shock index? A lot of papers on shock index that we should monitor it. Any idea?
Divided by BP, if it is more than 1, we call it
Sorry, your voice was not clear.
For the by BP more than 1, significance will be more than 1. Then we call it a shock index as possible, and the need for a blood transfusion has also been indicated if shock index is more than 1.
So what you are suggesting is a ratio of heart rate to systolic blood pressure.
Systolic blood pressure. Yes.
So the normal values would be 0.5 to 0.7. And what you are suggesting, if it is more than 1 or more than 0.9, then generally these are the sicker patients. And they're the role of intervention radiology, a role of operative intervention, or blood transfusion, everything increases. The severity increases, correct?
Yes.
Yeah, Dr. Ghawat, you were saying something.
No, about the shock index, it is, of course, the ratio of heart rate to blood pressure, systolic blood pressure. The values more than 1.3, usually they are associated with worst outcome. And, patients with head injury, values less than 0.7, where you would have bradycardia with hypertension. Again, the prognosis is bad.
So more reflective nowadays in even in dengue cases, also in PPH-induced massive blood loss, and maybe we can extrapolate in trauma, I don't know. But these are I think has been graded as they're giving some scoring system to make the patient sicker states in more pronounced way.
Actually, this is adding objectivity to otherwise a subjective subject. So one of the more objective parameters. Dr. Venkat, I think we have covered the subject very well, and congratulations to both Sindhuja and Vignesh for reading about trauma very well and answering most of the questions, even from the audience. So you had a lot of people from Indonesia watching your presentation and hearing the discussion. So Venkat, for your, Dr. Ghawat, would you like to say something before we hand it over
question,
to
what about giving calcium for patients with massive transfusion?
Yes.
I think we did not cover that.
So we give 1 gram of calcium to start with massive transfusion, sir. And for every 4th pack cell, we give again 1 gram of calcium.
Any rationale for that?
Calcium
Please go ahead, sir. Please go ahead, Ravindra.
Let them say.
So basically, you have to monitor the ionized calcium. You want to maintain it between 1.1 to 1.3. But what Venkat asked is, why do you want to give? What happens with massive blood transfusion? Why do you want to give?
Citrate will get accumulated. So citrate will cause binding with calcium, and that will cause
Chelation.
Yeah, chelation.
Okay.
So that will cause hypocalcemia.
The concept of giving it for every 3rd or 4th point is now fading away. Now, of course, if you have facilities available to monitor ionized calcium, it should be monitor based.
Your ABG gives you ionized calcium these days, so you can monitor it very well.
ABG gives you an ionized calcium. So you can just look into the ABG and accordingly give calcium.
If you have a signs of symptoms of hypocalcemia, and mainly they say if you find it in ECG, or you have any, as rightly pointed out, of ABG, which is suggesting low, then only supplement, because calcium is abundantly available in your body. You supplementing them in an empiric way in every 3rd or 4th or 5th has not been suggested nowadays. Any other complication you see with the massive transfusion like this?
Hyperkalemia.
Okay, that
hyperkalemia, TACO.
So hyperkalemia again may be considered because of this stored transfusion, but the amount of hyperkalemia which happens with this blood transfusion is very small. So that's a remote possibility that you will land up in hyperkalemia. You must have been seen many cases of transfusion. How many times you have seen a patient in hyperkalemia? They may happen with your acidosis of 6.8 or 6.7 pH because the patient is not perfusing to the organs. Okay, other you say TACO. Is it TACO common or something else we see more?
When you are answering, I'll interrupt here. When you are saying TACO, we expect you to give the full name in exam.
Transfusion associated circulatory overload, abdominal compartment syndrome, and hypothermia. These are the early complications which can see.
Other than the coagulopathy, which you already mentioned, anything else which is more common than TACO and abdominal compartment syndrome after transfusions, massive transfusions with blood products?
Apparently, will be present a bit late, but not in the
within 6 hours of transfusion.
What is TRALI? Again, you have used an abbreviation.
What is TRALI?
Transfusion-related acute lung injury, which causes desaturation. With onset within 6 hours of transfusion. It's like ARDS.
So which blood cells will cause TRALI?
Plasmas are known. Fresh frozen plasmas are known to cause.
And what is the advantage of using this?
PCCs are actually advantages.
Let me finish the question. Leukodepleted RBCs. What is the advantage of using them?
So
I'm sure Yashoda also gives only leukodepleted. They are giving 3 log leukodepleted blood now, RBC.
There are, again, it decreases the incidence of this trialing.
Hypothetically, TRALI has been associated with the immunogenicity related to the leukocytes. So leukodepleted has shown to drop the TRALI rates. So how do you differentiate between TACO and TRALI? You said both the things. Transfusion associated acute lung injury, transfusion associated cardiac volume overload state. How do you differentiate?
TACO is generally, I guess, similar to, will have an increased CVP, or IDCs will be full, more of an overload state. So when we give diuretics, generally those things needs to reverse. But in TRALI, more like an ARDS kind of a picture because of an inflammatory reaction which happened, and there is a leaky capillaries were there in the system. It behaves more like an ARDS picture, and the treatment again goes the same way of lung protective ventilation and supportive measures as well. And if we have an opportunity of measuring pulmonary capillary wedge pressures, which will be low in TRALI as compared to TACO, will have an increased pulmonary capillary wedge pressures.
Are you doing it? Are you measuring it?
No, sir. We don't use. And so we had
nobody is using a PA catheter. So anything that we can use for the same thing?
I think the best way which we see, as you said, there is always an indication that you have a full IVC with a plethoric lungs, and you give a diuretics test in them and they get normal. So that's where you see the TRALI doesn't happen that way. You give diuretics, it doesn't care at all. So you again go for like a ARDS ventilation. But what is your prognosis with the TRALI in many of the situations?
It reverses after 2 days. Most of the cases it reverses in 2 days time.
So if you ventilate them with like any ARDS protective lung ventilation, the prognosis remains to be good. But yes, they are ARDS patients. It's depending on the severity, they can play. So once you're talking about this massive transfusion and all this protocol, so you get a call from any trauma site and you are in the hospital receiving these cases. Okay, what is your preparation ideally should be done? What preparation are mandatory in many situations when you are actually receiving a patient or receiving a major trauma victim from a roadside?
If we know the blood group, then group-specific PRBCs can be. If we don't know the blood group, then O negative preferably. If not, O positive also can be given with PRBCs. And plasmas, A or AB group of plasmas, and any kind of platelets, any group platelets can be kept ready.
I think the question is broader, and he has given a hint that patient is being shifted.
Even infuser ready.
What do you do in your hospital? What does the ER do when they have a information that a major trauma is coming?
Polytrauma, major trauma, like
major trauma.
Present.
Do you activate a trauma code?
Yes, exactly. That is what I'm trying to point out. See, again, like your code stroke, your code blue, these are the things which has been now evolving, like you activate a code trauma or something like even a PPH, they say code massive transfusion activation. And these all things, sometimes if you are not in place, somebody keeping, as you said, the packed cells ready, cross-matched, or as you said, O negative, or your plasma ratio with platelets ready. Otherwise, you will have a problem. So that is one side, that your massive transfusion side, your lab side, you said. What are the other things you keep ready in your emergency?
We want team also to be ready.
Like, so you need a warmer, that your IV fluids which are there are prepared with at least in a temperature gone to a body temperature of 37 degrees. Those should be available. Your team should be ready, and in the team you need the team members who can actually handle those trauma. Like if you have, as you said, polytrauma, all these team members should be activated, and that's where this code trauma goes well. So these are the things where within a period of time is the institutional policy, like in a time of an hour. See, many of the times it is not that it will happen in the daytime. It can be happening in a holiday It can happen in a middle of the night. So all your team trauma should be available. Your orthopedician, your neurosurgeon, your GI surgeons, and all of them should be available there. And more importantly, nowadays we are relying more on the interventions done by the radiology IR department, as rightly pointed out by Dr. Ravindra, that many of these pelvic injuries, many of the facial injuries, we had come across situations where it is impossible to actually intervene in the base of skull fractures where your major arterial bleeds, which actually lead to deaths. As he said, initially they get stabilized by your initial resuscitation. After 15-20 minutes or a half an hour, an hour, you see dropping. So in those situations, IR team do play a role. I think that role will go up over a time as it comes. And Dr. Ravindra, you are pointing out for that area. What do you think about it? The role of interventional radiologist, early embolization, localizing the artery.
It's very important when, especially when the sites are not amenable to surgery. Like you said, pelvic injuries. It is very difficult to manage pelvic injuries when they are bleeding. And there is no one identifiable source. It's a plexus, so it becomes very difficult to manage. So there, apart from stabilization, there is a role for angioembolization.
And again, Dr. Venkat, Dr. Ravindra, please continue, please.
No, even in other vascular traumas, like particular vessel, if it's bleeding, many a times there are two schools of thought. One school would say we do a selected CT scan. The other school would say any patients with polytrauma, most of our hospitals, we follow a protocol of whole body CT scan. So if once the patient is enough resuscitated and stabilized, we do a whole body CT scan with, of course, contrast. If you see some active bleeding, which can be managed by angioembolization, nothing like it, you can avoid
that concept will probably evolve over a time.
No, this is already in place. That's what I wanted to say. Besides the initial interventions, if later in the course of patient recovery, you find that there is a generalized, bleed, the surgeon have already done the surgery, they can't find a source, say abdominal bleeding. So to locate the source of bleeding and to handle it also, there is a, role of intervention radiology. So I think information must go to the intervention radiology when a major trauma code is announced, to the cath lab as well as to the OR. Your patient may require urgent surgery. So these are part of the, trauma code activities.
So lab, radiology, emergency team, intensive care team, orthopedic surgeon, neurosurgeon, GI surgeon, and interventional radiologist. We're talking about a code trauma team, which actually, if it is in place in a flow, that will give you the whole support which you get during a code blue or a code stroke in many other situations.
Even anesthesia, I think, should be included.
Yes, very important. Yeah, in OT.
Because you might face a difficult airway situation.
Mandatory.
That's, I think, the OR team and their role in helping the anesthesia, airway management. Yes, cannot be.
I think we have covered the subject extensively, and if there are any questions remaining, we'll address them. Yeah, we can wind up now.
Yeah, so we'll over to Sasi.
Yeah.
The majority of my job also Rajesh sir only did. Nothing more. Thank you, Rajesh sir. Thank you, Ravindra sir. Thank you, Venkat sir, for sparing time and sharing your knowledge to all the students across the India and even abroad also. Thank you, Sindhuja and Vignesh, for bringing a good case for discussion. Thank you.
Thank you, the participants, especially the overwhelming participation from Indonesia. We are thankful to you.
So I feel, sir, the trauma cases have not been common in all the intensive care across. So many may be working in the medical intensive cares where the predominant role will be medical. So sometimes the trauma cases, when they come in exam, it became a very difficult part for the students. So we wanted to emphasize that all the students do cover trauma as one of their long case, because in exam, they may come across this. So by this case discussion, I thank all the teachers, moderators, both Pande sir and Ravindra, in spending their time. And it is an honor and a privilege to have you, both of you, here on board, sir. Thank you so much. And thank you, sir.
Thank you so much. Thank you, Sindhuja.
And Dr. Sindhuja and Vignesh, all the best. You did excellently well in presenting the case and you were quite good.
Thank you.
Thank you so much.